Now let me explain the conductive system of the heart, specifically its physiology and its function. First of all, we said that heart is made of three types of myocardium. One type is called atrial myocardium, another type is called ventricular myocardium, and the next type is called special myocardium. Special myocardium has some specific functions, okay, that I'll explain each of them one by one. For example, the conductive system of the heart is made of special myocardium. It means we don't have rule in contraction or in systole of the heart, okay. They don't play a role in contraction of the heart, okay. They produce some specific functions. For example, first of all, conductive system is made of 4 and 5 parts. First one, it's made of AC node, okay. I talked about all of them in previous lecture. And AC node is also called sinoatrial node, okay. And sinoatrial node is a group of cells, okay, that inside these cells we have less filaments, less conjunctile filaments, okay. So this group of cell is located in the right atrium near the superior vena cava, and in the posterior wall of the right atrium where the superior vena cava is opening. But anyway, this group of the cells are called as a collectively SA node or sinoatrial node, okay. The next part of conductive system, from this AV node for SA node, for example, these cells are cells of SA node. These cells of SA nodes are interconnected to each other by gap junctions. Then some special cells come here, okay, and these cells are also interconnected to each other by gap junctions, like this, like this. These are made of cells, okay. So this pathways going from the right atrium to the left atrium, and this is called interatrial tract, okay. Interatrial no this is called this is called interatrial tract, or sometimes it's called Beckman bundles or Beckman's bundle, okay. This is one thing. Another, from this AV node some cells come here, and they are coming from the SA node to the AV node, and this pathway is called internodal pathway because it is between two nodal cells. And here we have AV node, and AV node is located in right atrium superior to the this fibrous ring, okay. I'll talk about each of them one by one, don't worry, okay. Now this internodal pathway is made of three tracts: anterior, posterior, and middle, okay. Then this is AV node. For example, this is AV node, this is AV node. AV node is made of group of cells, and these cells are interconnected to each other by gap junctions. Then from the AV node a group of cells emerge, okay, and this group of cells are called bundle of His, and they are interconnected to each other, and they're also special myocardium. Then here, this is this part. Let me color this part. This part is called bundle of His, and His is related to the name of a person. Then after the bundle of His, two bundles emerge, right and left, okay. So this one is called right bundle branch, and this one is called left bundle branch, okay. Then this is right bundle branch, this is left bundle branch, and left bundle branch gives two more branches, which are anterior and posterior hemifascicles. But anyway, then from each branches group of the cells emerge, and these small projections of special myocardial cells which are interconnected to each other by gap junctions, they are called Purkinje fiber. So as a collectively conductive system of the heart is made of AC node, it is made of AV node, it is made of interatrial pathways, it is made of internodal pathways, it is made of bundle of His, it is made of right and left bundle branch, and it's made of Purkinje fibers. Okay, now let me explain all of them one by one and what specificity they have. Okay, first of all, about the SA node. SA node. SA node and AV node. Okay, keep it in your mind that, for example, this is a cell. When a cell goes from resting membrane potential to action potential spontaneously, without external stimulation, without stimulated it by hormone, by nervous system, by drug, by anything. When a cell goes from resting membrane potential to action potential automatically, this phenomenon of the cell is called aromaticity. This phenomenon of the cell is called aromaticity. So, point number one, all parts of conductive system have this phenomenon of aromaticity. They are going from resting membrane potential to action potential automatically. I'll explain. This is one point. Point number two, aromaticity in AC node is faster than AV node. Aromaticity phenomenon in AV node is faster than Purkinje system. As a collectively bundle of his bundle branches in Purkinje fibers, all of them are called Purkinje system. Okay, so SA node, AV node, Purkinje system, all of them have aromaticity phenomenon. Next one, aromaticity is faster in AC node than AV node and in AV node than Purkinje system. Now what's the importance of this concept? During normal situation, this is AC node. AC node produces, I'll explain its mechanism. AC node produces depolarization and repolarization or action potential, and this action potential is then spread out to all cells by the gap junctions, and this action potential or depolarization and repolarization causes contraction of the heart, and we have studied that in previous lecture, that how a skeletal muscle is going to the contraction by the action potential, and also today we will talk about it, but don't worry. Now during normal situation, AC node is going to depolarization and repolarization faster than AV node. Okay, so when it produces depolarization and repolarization, it causes contraction of the heart. It means contraction of the heart during normal situation is under the control of the AC node. So that's why AC node is called pacemaker. This is called pacemaker. What do I mean by pacemaker? Pacemaker or a pacemaker is a cell or pacemaker are a group of cells, okay, that they control contraction of the heart. For example, if you damage AC node, okay, for example, during ischemic heart disease, okay, during ischemia, when AC node is damaged, now the control of the heart or depolarization and repolarization or systole and diastole of the heart is under the control of AV node, because speed of AC node, it means AC node is going to depolarization and repolarization around 60 to 100 times per minute, and automaticity speed in AV node is around 40 to 60. Now during normal situation, you will have each depolarization and repolarization causes one heartbeat. one systole and diastole of the heart. We'll talk about it in cardiac cycle. Now, 60 up to 100 times of aromaticity, or when a signal is going from resting membrane potential to the action potential, causes 60 to 100 beats of the heart in 1 minute. Okay, so now when you damage the AC node, now AV node is going to depolarization, or it acts as a pacemaker, and AV node produces heartbeat. But now heartbeat is less than AC node, and it will be around 40 to 60. And when you destroy AV node, now heart control or systole and diastole of the heart is under the control of Purkinje system. Now Purkinje system acts as a pacemaker, and the speed of Purkinje system is around 20 to 40. If you don't treat this person, it will go to shock or bradycardia as soon as it's possible. Got it? So that was the concept of pacemaker. Sometimes ectopic foci, ectopic areas firing, and the drive contraction of the heart, and these are called ectopic pacemaker that causes arrhythmias of the heart. So now these were specific functions of AC node and AV node. Okay, sorry we lost connection of camera, but anyway, let me explain specific functions of each parts of conductive system one by one. The specificity of AC node is that it acts as a pacemaker. This is specific function of AC node. Okay. About the AV node, atria are separated from the ventricle by fibrous skeleton. Okay, so when you want to pass these action potential from atria to the ventricles, or from AC node to the ventricles, we have only one way, and this way is AV node. It means that AV node is connected to the atrial myocytes by the gap junctions, and atrial myocytes are connected to the AC node by the gap junctions. So depolarization and repolarization comes through the gap junctions to the AV node. Then from the AV node it passes to the ventricle. Okay, this is very important because sometimes we have accessory pathway that connects depolarization and repolarization from the atria to the ventricles. For example, this is called Wolff Parkinson's White syndrome. Okay, so like this, that's why the only way to connect depolarization and repolarization from the AC node or from the atria to the ventricle, this is AV node. So this is a specificity of AV node, that it conducts depolarization and repolarization from the atria to the ventricle, or it acts as a conductive system. Okay, about the Purkinje system. Okay, listen me carefully. I explained before, or I said that these two ventricles act as a sensation. It means they contract together. They go to systole and diastole together. That we'll talk about the mechanism of this under the title of cardiac cycle. But now we know that left ventricle is thick than the right ventricle. Okay, for example, left ventricle is made of 10,000 cells and right ventricle is made of 1,000 cells. Now when you pass depolarization and repolarization from one cell to another cell, so now when you pass it through 1,000 cells, it takes, for example, 0.5 seconds. But when you pass this depolarization and repolarization through gap junctions among 10,000 cells, it takes, for example, 0.8 seconds. So first right ventricle contracts and then left ventricle contracts. So that's not sensation. So that's why we need to hear a system, a wire-like system. So this system is Purkinje system inside these cells, and these branches are going deeply inside the both ventricles. So when depolarization and repolarization reaches to these special cells to Purkinje system. The cells of Purkinje systems are very large, and the gap junctions here are larger and more, so they conduct the depolarization and repolarization so fastly to all myocardium, to both left ventricle and right ventricle, and that's why it causes these two ventricles to contract simultaneously. Okay, so the probability and the specificity of the Purkinje system is that it helps our heart in to act in sensational manner. Okay, got it. So now, the last part of this topic. Now, let me talk about depolarization and repolarization of the cardiac muscles. First of all, listen me carefully. I'll explain first of all that how AC node is going from the resting membrane potential to action potential spontaneously. It means how it acts as a pacemaker and how it acts as a automaticity. Okay, so now this is AC node. Then I'll talk that these charges or these depolarization and repolarizations, how they pass from the AC node to the myocardium and atrium and causes contraction of cardiac cell. This is the easiest part. Listen me carefully. Resting membrane potential in acinodal cells or in avinodal cells. In both of them are around negative 60 millivolts or negative 55 to negative 60 millivolts. And other types of myocytes, like in atrial and ventricular Purkinje system, the resting membrane potential is around negative 90. I'll explain that why here this resting membrane potential is less than the atrial and myocardial myocytes. Don't worry. Now, during rest, this is around negative 60, and that's because in AC nodes, we have an AC node and AV node by KG system in all of them, but specifically in AC node and AV node, we have some channels, and these channels are called funny channels. These are called funny channels. Now, these funny channels are leaky for these funny channels are leaky for calcium and sodium. And we know that we have more sodium and calcium outside of the cell than the inside of the cell. So, and these are positive charges. So we flow from high concentration gradient to low concentration gradient, and they cause the resting membrane potential to be less negative, around negative 1654. Plus these charges flow. For example, this is rest. They flow or like this, and a time will reach that I'll reach to the threshold potential. And we know from previous lectures that threshold potential is a specific voltage inside the cell, okay, inside the excitable cells or those cells that they're going from resting membrane potential to action potential. So here threshold potential is a specific voltage in which specific voltage gated channels are opened. Got it? Now specific channels are opening. Got it? Now, from rest to threshold, I'm going automatically by the help of these funny channels. Okay, and here threshold potential is around negative 40 millivolts. Okay, when I reach to negative 40 millivolts, automatically new voltage channels will be opened, and these channels are called L type calcium channels or lead type calcium channels. And we have a lot of calcium outside of the cell. Okay, I'm talking about that how AC node acts as a pacemaker and how it produces depolarization and repolarization automatically. You can look at it that There is no external stimulation. Automatically, these charges come inside to the cell. Got it? Now, when I reach to threshold, calcium voltage gated channels are opening. When now these calciums flow inside to the cell, and now I'm going from threshold potential to a positive state, which is called depolarization. And when I reach to plus 10 millivolts, okay, now in this point, new channels will be opened, and these voltage gated channels are called potassium voltage gated channels. And potassium go and all these potassium ions go from the inside of the cell to the outside of the cell from a high concentration gradient to low, because we have more potassium inside of the cell. And this cell come back to repolarization state. Okay, then again I'm going from resting memory potential by the help of funny channels. France also after funny channels, some calcium channels are also opening, okay, by the help of funny channels. But anyway, I'm going to which state to threshold, and once again another depolarization and repolarization is produced. So now this is one depolarization and repolarization. So now this depolarization and repolarization flows from by this membrane, which is called propagation of action potential, that we have talked about it in previous lectures. But anyway, now these positive charges, these a lot of calciums, these a lot of sodiums, okay, listen me carefully, that we don't have sodium voltage gated channels here actively. If we have, they are deactivated by this negative charges, okay. And you know that when you stimulate again and again sodium voltage gate channel, it closes its deactivated gate. But anyway, we don't have these channels here. Now these positive charges come from AC node to the atrial and ventricular myocytes. For example, this was AC node. Now AC node produced a lot of depolarization and repolarization, and these charges flow from AC node to these neighbor cells, to the cells of atrium by gap junctions. Now, when these positive charges come to the ventricular cell or to the atrial cell, it causes contraction. And this mechanism is called excitation, contraction, coupling. Let me explain this, that how excitation of the myocardial cells causes contraction of the myocardial cells, and contraction means systole of myocardium. Anyway, now these are positive charges. Now during rest, this is a ventricular myocardium, okay, this is a ventricular myocardium or atrial myocardial cell. Now during rest, the atrial myocardial cell, for example, this is resting membrane potential, this is threshold potential. Resting membrane potential here is around negative 90 millivolts, because here we don't have sodium and calcium leaky channels. Here we have only potassium leaky channels, and potassium is always going from the inside of the cell to the outside of the cell. Plus we have sodium potassium pump, which pumps 3 sodium outside of the cell and 2 potassium inside of the cell, and both of them causes the resting membrane potential to be negative 90 millivolts, that we have explained it in previous lectures, okay. But anyway, now arm at rest, ventricular cell is at rest, positive charges come to the ventricles from the AC node here, okay, automatically without external stimulation. Now when positive charges come here, I'm going from resting membrane potential to threshold potential, okay. Now in threshold potential, here is around negative 60 or negative 70 millivolts or negative 65 millivolts. It depends on different references and textbooks. But anyway, when I reach from resting membrane potential to threshold potential, now in this point here, new voltage gated channels will be opened, and these voltage gated channels are for sodium. Don't get confused here. Therefore, sodium. Here, voltage gated channels were for calcium. It means depolarization. Depolarization of AC node and AV node is depending on calcium, and depolarization of atrial and ventricular cells are depending on sodium. Got it? Now, a lot of sodium enters to the cell, and I'm going from threshold to positive state, which is around plus 20 millivolts. Listen me carefully. Here, here, this is the difference between the depolarization and repolarization of cardiac cell with the skeletal muscle cell. In skeletal muscle cell, at this point, potassium voltage gated channels open, and I'm going back from depolarization to repolarization state. But here in cardiac cell, first these potassium voltage gated channels will be opened, and a lot of potassium go out from the cell, and I'm coming back to the repolarization state. But with a bit delay, by this positive charges, a type of calcium voltage gated channels are opening, and a lot of calcium enters to the cell, plus this voltage gated channel which were open previously, this will be deactivated, okay, and its activity decreases around 5 folds, okay. And with calcium, another type of potassium channels are opening, that these slower compared to these previous potassium channels, and a lot of potassium goes out of the cell. Now calcium is positive charge, a lot of calcium enters to the cell. Potassiums are positive charges, a lot of potassium go out from the cell, okay. Now when I lose positive charges and I gain positive charges, there will be no net fluctuation in my graph. So for a moment my graph remains in plateau state, okay, and this state is called plateau. This is called plateau phase. So listen, be careful. First of all, depolarization comes to the myocardium, and then myocardium is going from the resting membrane potential to the threshold potential, and threshold potential sodium voltage gated channels open, okay. And then after that, at the peak of depolarization around plus 20, potassium voltage gated channels will be opened, and these are fast, and with a bit delay sodium voltage gated channel, with a bit delay calcium voltage gated channel plus another type of potassium voltage gated channel will be opened, and these previous potassium voltage channels are getting closed, okay, or getting deactivated. Got it? Now this plateau phase is due to efflux of potassium from the inside of the cell to the outside of the cell, and from the influx of calcium from the outside of the cell to the inside of the cell. Now here, after a bit delay, this type of potassium channel will be activated again, and a lot of potassium goes out of the cell, okay. And I'm coming back to the resting membrane potential, okay. So now this curve causes contraction of myocardium. How? Listen me carefully. Listen, first of all, let me tell you these phases. This resting phase is called phase 4. This depolarization phase is called phase 0. This fluctuation is called phase 1. This is called phase 2. This repolarization is called phase 3. Plateau is phase 2, okay. And again, the resting state is called phase 4. Here in SA node, this is phase 4 because this is resting state, and we don't have resting state here because of influx or leaking of calcium in sodium ion channels. Depolarization state is phase 0, okay. this stages, we don't have phase 1, we don't have phase 2, so this stages phase 3, and again this stages phase 4. Got it? Now here listen me carefully how this depolarization causes contraction of myocardium. In this phase, in plateau phase, a lot of calciums enter to the cell. This calcium has some functions. For example, the first function of this calcium, okay, this is a T tubule, okay, this is a T tubule, and we have these channels of calcium inside the T tubule, which is opening in phase, which are called L-type calcium channels. Sometimes they are called dihydropyridine receptor. But anyway, during entering of a lot of calcium, okay, this calcium causes activation of a channel on the sarcoplasmic reticulum of this cell, which is called RY R2 channel, okay, or ryanodine receptor type 2 channels. And this receptor, when it activates, it pumps a lot of calcium to the cytosol. So we brought calcium to the cytosol from two sources by two ways. One from the endoplasmic reticulum or sarcoplasmic reticulum, next from the extracellular calcium. This extracellular calcium is very important, okay, because this calcium causes activation of this RY2 receptor, and by the activation of RY2 receptor, we bring a lot of calcium from the inside to the outside, and this calcium causes contraction of myocardium. I'll explain it now. If you put this heart in a solution, okay, in a solution which is free of calcium, which doesn't contain calcium, and also you put a skeletal muscle cell in that solution, so in same time the skeletal muscle cell contracts, but cardiac muscle cell doesn't contract. Why? Because we don't have extracellular calcium. The solution is free of calcium, and the contraction of myocardium is depending on the extracellular calcium. That's why this extracellular calcium is very important. One function of this extracellular calcium is that it causes platypus. The next function of this calcium is that it causes efflux of calciums from the sarcoplasmic reticulum. Now, these calcium comes, and we know from previous lectures. After that, contraction of myocardium is same as the contraction of skeletal muscle. Now, these calciums, okay, these a lot of calciums come here. There's a lot of calcium come here, okay, and the activates troponin C, or the join to troponin C, and then troponin C activates troponin I and troponin T, and troponin T and troponin I. When we remove troponin T and troponin I by the help of troponin C, so now thick filaments are binding to the thin filament and causes contraction. That's why we called excitation contraction coupling. That have excitation of a myocardial cell causes contraction of a myocardial cell. So when a synode produces depolarization and repolarization, all these charges, all these depolarization and repolarizations go from one cell to the next cell by gap junctions, and all myocardium is going to contraction, and the contraction of myocardium is called systole. And when this graph come back to repolarization state, so heart is going to relaxation state, which is called diastole. So during systole, heart pumps blood, and during systole, heart accumulates blood inside it. That we'll talk about it under the title of cardiac cycle. So these were depolarization and repolarization of AC node and also AV node and myocardial cell. So that's why I said before that AC node acts as a pacemaker, and AC node has a specificity of autonomic meticity. Got it? Now, the last but not least, I'll talk about before I'm talking about the sympathetic and parasympathetic nervous system effects on the heart. Let me explain these graphs. This graph is for AC node. Okay, this is phase 4. Okay, we don't have resting stage and AC node. This is depolarization, which is due to entry of calcium. This is repolarization, which is due to efflux of potassium. Okay, we explained it here. So this one graph causes one heartbeat, one loop. Okay, now this next graph causes another heartbeat, loop, loop. Okay, so during rest, when your heart rate is in 72, each each depolarization phase and repolarization phase takes around 0.8 seconds. Okay, so your one heartbeat or one systole and diastole takes 0.8 seconds. That we'll talk about this under the title of cardiac cycle, but don't worry. This graph is for AV node. Okay, so AV nodal depolarization and repolarization a bit slower than the AC nodal depolarization. That's why this acts as a pacemaker, and this is not a pacemaker cell in a normal healthy heart. Okay, this graph here, this for Purkinje system, and in Purkinje system we have platyphase, and also in atrial cells we have, this is for example atrial cell, and this one is for ventricular cell. So the platyphase in ventricular myocyte is longer than all of the other cells. Okay, so this was graphic presentation of different cells depolarization and repolarization. Now I'm going to talk about effects of sympathetic and parasympathetic nervous system on the heart. It means these were intrinsic pathways and stimulation of cardiac cells. What are extrinsic stimulations of the cardiac myocytes? So now let me explain the effects of sympathetic and parasympathetic nervous system. In previous lecture, we talked about the anatomy of the heart, and also we talked about innervation of the heart. We said that we have nervous system. Nervous system is made of two parts, CNS and PNS, central nervous system and peripheral nervous system. Central nervous system is made of brain and spinal cord. This is spinal cord. Okay, and peripheral nervous system is made of sensory and motor system. Sensory, which carries sensation to the nervous system, and motor, which carry information from the central nervous system to the peripheral, or causes production of activities in our body. But anyway, motor nervous system is made of somatic nervous system, which is under our control, and skeletal muscle cells are innervated by somatic nervous system, which comes from the anterior gray horn, and heart is innervated by autonomic nervous system. Okay, and we have two types of autonomic nervous system is divided into sympathetic nervous system, parasympathetic nervous system, and sometimes GI or gastrointestinal innervation. But anyway, now heart is innervated by sympathetic and parasympathetic nervous system. Keep it in your mind that when sympathetic nervous system is activated in your body, it causes your heart rate to be increased. Okay, for example, it increases heart rate. Okay, but when parasympathetic nervous system is activated, it decreases heart rate. Okay, now let me explain this point, that how sympathetic nervous system increases heart rate and how parasympathetic nervous system decreases heart rate, because we have a lot of drugs that affects these two systems. Okay, now I'll talk about the clinic at the end of this lecture. Now, sympathetic nervous system, it releases a neurotransmitter which is called norepinephrine. Norepinephrine. Okay, and also we have circulatory epinephrine also, that is released by adrenal medulla. Okay, now epinephrine, which is released by adrenal medulla, and norepinephrine, which is released by sympathetic nervous system, plus external injection of epinephrine and norepinephrine, all of them act on our heart. Okay, so now we have different types of receptors for epinephrine or for sympathetic nervous system, and these receptors are called alpha and beta, and we have alpha 1, alpha 2, beta 1, beta 2, and also beta 3 receptors. Okay, now the receptor for sympathetic nervous system, or the receptor for norepinephrine and epinephrine on our cardiac cell, is called beta 1 receptor. This receptor is called beta 1 receptor. Now, this beta 1 receptor is 7 pass receptor. It passes through the cell membrane 7 times. Okay, so now this is epinephrine or norepinephrine. When you stimulate beta 1 adrenergic receptor, now inside the beta 1 adrenergic receptor, we have a globular-like protein. Sometimes this receptor is also called, the 7 pass receptor is also called serpentine receptor, okay, because it's snake-like, and also sometimes it's also called G protein coupled receptor because it's coupled to a globular protein inside to the cell. Now, this globular protein, we have different types of these globular proteins. Some are called GS or globular S or stimulatory proteins. Some are called GI. Some are called GQ. Okay, so now beta 1 receptor is joined to the globular protein, which is called GS globular protein. Now, when we stimulate this beta 1 receptor, it activates this globular protein. This globular protein is made of 3 parts: alpha subunit, beta subunit, and gamma subunits. And all of them are called alpha S, beta S, gamma S because these stimulate our heart, they stimulate the contraction of the heart. That's why they are called GS or G stimulatory proteins. Now, when you stimulate these G proteins, this alpha subunit has, during unstimulated phase, it has GDP, it has GDP. Okay, when you stimulate it, it releases GDP and it takes GTP. So it takes GDP, it takes GTP, and it releases GDP. Got it? Now this GDP has energy or phosphate inside it. When you stimulate this G protein is dissociated in 2 parts. One part is called beta and gamma, that they're going together, and another part is called alpha. Now, this alpha S has GTP with it. Now, this alpha S goes and it stimulates a beautiful transmembrane protein, which is called adenylyl cyclase. Now, adenylyl cyclase is stimulated by this alpha or by this alpha part of GS protein. And with it stimulates adenylyl cyclase, it converts this GTP to GDP. It means it loses its 1 phosphate. GDP means guanylyl triphosphate, it has 3 phosphate, and GDP means guanylyl diphosphate, it has 2 phosphates. So phosphate is energy. When you lose phosphate, this phosphate will be added on adenylyl cyclase, and adenylyl cyclase will be stimulated. Now, adenylyl cyclase converts ATP, adenosine triphosphate or ATP, into cyclic AMP in a stored type of adenosine monophosphate. Now, this cyclic AMP then activates a beautiful protein which is called protein kinase A, and kinase are those proteins which phosphorylate other types of proteins. Now, this protein kinase A, number 1, it phosphorylates the L-type calcium channels, and it enhances the function of this L-type calcium channels, and a lot of calcium enters to the cell. And I'm going from the depolarization to repolarization state very fastly, plus I will have a lot of calcium inside the cell. This is one point. Then this protein kinase A also stimulates this receptor, which is on the sarcoplasmic reticulum, or which is called RY2 receptor. So a lot of calcium come out from the sarcoplasmic reticulum also. Okay, so in a nutshell, it increases contraction of myocardium, plus it increases speed of depolarization and repolarization, for example. And also this protein kinase A, for example, we have this system in acidoidal cell also like this. Also, this protein kinase A stimulates these funny channels. When you stimulate funny channel, you enter the calcium and sodium fastly to the cell. When you enter the sodium and calcium fastly to the cell, you go from resting state to the threshold fastly. Then when you stimulate L-type calcium channels, you go from depolarization to repolarization fastly, and then you will come back to repolarization fast. Then you go fast, then you come back. So that's why it causes the heart rate to be increased, and this is called positive chronotropy. Okay, positive chronotropy means that when you increase the heart rate, okay, and also it increases dromotropy. It means it increases function of AV node and conduction of the repolarization from the atria to the ventricles. And also when you increase contraction of the heart, this is called positive inotropy. Got it? So this was the effect of sympathetic nervous system on the heart. And clinically we have a lot of drugs, okay. And also we have lositropy. Lositropy means that these potassium channels, which causes repolarization, they're also affected by the sympathetic nervous system, and depolarization step is also increased. Okay, this is called lositropy. It means the diastole phase also, the heart is going to diastole faster than previous. Okay, now we have a lot of drugs, for example, beta blockers. Okay, atenolol, propranolol, all carvedilol, all of them are called beta blockers. Okay, and you use beta blocker here to block these beta receptors. When you block the beta receptors, you decrease the heart rate, you decrease the contraction of the heart, and then you decrease the BP or blood pressure that we'll talk about them in internal medicine. Also, we have some calcium channel blockers that they block these L-type calcium channels, and they also causes the heart rate to be decreased, and also the causes blood pressure to be decreased, and they're used in hypertension and other cardiac disease. Okay, also we have potassium channel blockers. For example, they are amiodarone. That's why all these channels are so important. Amiodarone, they're used in arrhythmias. Okay, also we have sodium channel blockers. These fast sodium channels are blocked by these drugs, and these drugs are, for example, procainamide and lidocaine. Now let me explain the effects of parasympathetic nervous system on the heart. It's easy. We have receptors for parasympathetic nervous system only on AC node and AV node. We have some of them on myocardium, but they're less. So it means that AC node and AV node is more influenced and affected by the parasympathetic nervous system. And we have beta 1 receptor on AC node, AV node, and all types of myocardium. Now, for example, parasympathetic nervous system releases acetylcholine. This is a neurotransmitter. This is so easy. Okay. Now, when you stimulate this receptor for acetylcholine is also 7-class receptor. This is also G protein coupled receptor, but this time the G protein is GI protein or G inhibitory protein. Here it was GS protein or G stimulatory protein. When you stimulate this receptor by acetylcholine, now acetylcholine, when you stimulate this, G protein will be activated, and when you activate G protein, this is GI protein. This protein is dissociated into two parts, and beta and gamma, gamma and alpha. This alpha subunits comes here, it stimulates adenylyl cyclase, but listen carefully. Here it stimulates adenylyl cyclase in positive direction. Here it stimulates because it's GI protein in negative direction. So when you inhibit, it means when you inhibit adenylyl cyclase, it cannot convert ATP to cyclic AMP. When you don't have cyclic AMP, you cannot activate protein kinase A. When you don't have protein kinase A, you cannot activate ryanodine receptor B. You cannot activate these calcium channels. So it causes the heart rate to be decreased. Okay, it means it decreases the heart rate. Got it? Now another important, the beta and gamma subunit here in AC node and AV node causes activation of potassium channels, and you know that a lot of potassium go out from the inside of the cell to the outside of the cell. Here my resting memory potential was around negative 60, but when I lose a lot of potassium, so it means I lose a lot of positive charges, so the cell is going from negative 60 to negative 70 to negative 80, and it's going furthermore to the negative state. Okay, so now when I go from this state to the threshold, it takes time. Okay, so that's why it causes the heart rate to be decreased, or it decreases the heart rate. So sympathetic nervous system effect on the heart causes positive inotropy, positive chronotropy, positive dromotropy. Parasympathetic nervous system effects on the heart causes negative dromotropy and negative chronotropy, or decreases the heart rate. Got it? This is heart rate, I think. Okay, now these were all about the effects of sympathetic and parasympathetic nervous system on the heart. And also we have a drug which blocks this receptor. The receptor for acetylcholine here is muscarinic type 2 receptor, because we have different types of a receptor for acetylcholine in our body: muscarinic type 1, 2, 3, 4, 5, and also some other channels which are called nicotinic channel. But anyway, here the receptor for acetylcholine is muscarinic type 2. We have a drug which blocks this muscarinic type 2, and this is called atropine. And atropine is used by doctors during severe bradycardia. It means when a patient comes to you and his heart rate is less, he is in bradycardia state. When you block the effects of parasympathetic nervous system, so sympathetic nervous system will, so the effect of sympathetic nervous system increases here and causes the heart rate to be more. Got it? So these were all about the myocardial cells, about the rhythmical excitation of the heart, about the atomicity, about the pacemaker, about how AC node and AV node produces depolarization and repolarization. So have a good time till next lecture, and in next lecture, inshallah, we will talk about the cardiac cycle, that how this heart is going to systole and diastole, and which phases are there in systole and diastole of the heart. Have a good time till next lecture.